Good morning. My name is Katherine Davies and I'm one of the head and neck oncology surgeons working in Aintree Hospital. I'm sorry I can't deliver this in person, but I'm grateful for the opportunity to tell you about the work I've been doing with Cancer Alliance to try and improve patient pathways. The aim of this talk is to describe our current pathway for suspected head and neck cancers, what led to the creation of our rapid diagnostic clinic, the creation of our local risk calculator, the utility of a national risk calculator for triaging, and future directions. We know that head and neck cancer is the 8th most common cancer in the UK. About 12,000 cases are diagnosed per year. The majority of patients are diagnosed at stage 3 or 4, and our 5-year survival for many cancer sites falls below that of the US and Canada and many European countries. To get a referral into a rapid access clinic, there are only a number of discrete symptoms, and the ones on the right, dysphagia above the sternal notch, unilateral otalgia, unilateral nasal obstruction, and persistent sore throat, were removed with the renewal of the NG12 in 2015. On top of this, there are a number of GP proformas from around the region, and so this makes it increasingly difficult for our colleagues in primary care to know when and how to refer patients in, and whether it is to maxillofacial or to ENT head and neck services. We also know that if a patient comes in with sore throat, who's a heavy smoker, who drinks, who's got severe unilateral otalgia and has pain or difficulty swallowing, is very likely to have a head and neck cancer. However, they don't actually fulfil the requirement for referral through to a rapid access clinic. The NHS long-term plan strives to have an extra 55,000 people survive each year for 5 years or more following diagnosis, and 75% they want to be diagnosed at an early stage. This is particularly important in head and neck cancer, as a great proportion of our patients present at higher stages and therefore only have access really to more morbid treatment options, and in some stages no treatment options at all. It is not unusual for them to present with severe breathing difficulties necessitating emergency airway management or complete dysphagia. The reasoning behind this is to improve quality of life outcomes, improve patient experience, to reduce variation across the country, and also to reduce inequalities. So what did we do? Initially, in 2018, I audited all patients who presented to Aintree to the Rapid Access Clinic. In this, we documented their risk factors, why they were referred, the symptoms, investigations they had, number of appointments, and what their ultimate diagnosis was. Firstly, with the help of some of our GP colleagues who worked closely with the Cancer Alliance, we created an updated GP Proforma, in the view for hopefully rolling this out across the whole of our CCGs. This added in a number of supplementary symptoms, which through the audit that was done in 2018 were found to be symptoms that had a higher predictive value of a patient coming in with a head and neck cancer. We still had all of the symptoms and the forms that were needed to conform with the national guidance, but we added in this supplementary section at the end. We also, as you can see in the diagram, added in a simple drag and drop circle, which meant that if a patient presented with a neck lump, they could move it over to the area, as sometimes it was difficult with a description to get an accurate referral picture. Using the data collected, with the Cancer Alliance we managed to create a rapid diagnostic clinic. This allowed us to have the same day access to ultrasound, with an FNA if appropriate. There was a cytologist that was present, and we could often get same day results, and also adequacy for thyroid FNAs. The majority of head and neck cancers were then able to get cross-sectional imaging within 24 to 48 hours. It is obvious to see how this could then improve the pathway and also reduce patient anxiety. Our rapid access clinic was then audited after this implementation, and we showed that we increased same-day discharges from 31 to 73%. This saved 239 follow-up appointments, which meant that these could then either be used for new patients and gave more allowance in the clinic for further patients to be seen. All patients who had a head and neck cancer had cross-sectional imaging, which include in our region an MRI scan of the neck and a CT scan of the chest within 1 day. Patient experience was also audited and feedback forms were filled out, and this showed that there was improved patient experience. Not only did the majority of patients who were referred in with anxiety because of their new symptom could be reassured and discharged, but other patients could be seen in a clinic in conjunction with our head and neck specialist nurses and were given good information and time to talk through their anxiety and concerns. This then improved how quickly they could move through the diagnosis in their pathway. Despite these improvements, however, there was still a number of 62-day breaches. And although our aim isn't to reach the 62-day target, we should strive to see patients as quick as possible and to move them through far quicker than this. However, it is what we are guided by and what we are audited on. So therefore, it is a benchmark that we often use when assessing how well we are doing in a pathway. Most patients who breached only breached by less than 7 days. So therefore, it's a very narrow window of which we were not reaching this target. Due to increasing numbers of referrals through from primary care, in guidance with trying to get more patients through the pathway so that patients are seen at an earlier stage, a proportion of these have to be seen by non-head and neck consultants, as there are only so many that the head and neck team can see in a week. If this is done, there is an inherent delay of roughly 2 weeks, while that patient then gets transferred to a head and neck clinician. So what can we do to try and improve this? Using our 2018 data, we created a statistical model to try and identify patients who were referring in with a certain group of symptoms, their likelihood of having a head and neck cancer. We did want to add in local geographical data to try and create a local model that was particularly specific for our area. However, the numbers were too small, but this is something that we will continue to work on. We wanted to use this model to triage all referrals that came into cancer services. The aim of this can be seen here. We wanted to receive the referral in cancer services, perform a risk calculation using the model. If the patient was high risk, they would see a head and neck consultant in under 7 days or as quickly as possible, and a low risk patient could be seen by any ENT clinician up to 14 days. It's important to stress that at no point were we ever going to go further than the national guidance, and we would obviously strive to see patients as soon as possible. However, the higher risk patients would be prioritised. Our work was done in 2018, and just before and following on from this time, a team from London and Birmingham were also creating a risk calculator. They had a large number of patients from multiple centres, which was then validated, and they created an online risk calculator. This was then adapted and improved upon, and they released a second free access version. This was used widely throughout the COVID pandemic, when we were unable to see many patients face to face. This online model had been fully validated and had used more patients than we had, and so therefore we felt it was important to use this as our method of triaging patients. It consists of a form that is accessible online. There are a number of questions including age, gender, and number of symptoms, all of which are included in our new GP referral forms with the supplementary symptoms. So what are we wanting to do in our study? We've just been granted ethics to carry out this pilot study to look at triaging of all patients who've been referred into the rapid access pathway. The aim is that when a referral comes through to our cancer services, either one of the clinicians or one of the clerks will contact the patient, and using the validated free access risk calculator will ask the patient a number of discrete questions. Those questions will then translate into a risk of that patient having a head and neck cancer. And as shown previously in the diagram, patients who are deemed to be high risk will be triaged into seeing one of our head and neck cancer specialists and hopefully be seen in less than 7 days or as soon as is practicably possible. Patients who are then deemed to be lower risk of having a head and neck cancer will be seen by any of the clinicians and can be at a less speedy time frame. As had been said previously, however, this will still conform to the national guidelines of being seen within 14 days. We will then be in concordance with our protocol, keeping outcomes of the patients, of which patients have been triaged as high risk and low risk, and what the diagnoses of the patients are. We will then be collecting longer term data on what the patients' diagnoses are, whether the patients who are in a high risk or low risk are seen appropriately, and to make sure that no one falls into the wrong category, and also to see if the patients who are triaged as high risk and who end up having cancer, whether this actually does improve our 62-day breach rate. This will form part of a pilot study to see if this does improve patient pathways. Intuitively, it feels that this will make sense. However, we need to make sure that this is something that translates in reality and also something that can be practically used in the future. Ideally, what we want to do is to create a product which we can embed into primary care referral pathways. This is something not to add any workload to our primary care colleagues, but to actually make the triaging and referral process easier. We would ideally like them to be able to mark all of these symptoms on a risk calculator score, which would serve as the referral through to cancer services. This would then come through as a referral to our cancer service department and would then come through with an automatic risk score. This means that then the cancer services can allocate them to the appropriate clinic, either in a quicker time frame with a head and neck clinician or within the 14 days, but potentially with a non-head and neck clinician. There are obviously a number of hurdles with this moving forward, particularly the different numbers of computer systems and referral forms in through to cancer services, and also the fact there are a huge number of GP practices throughout the region. However, I think if we can show that this is effective, improves patient pathways, and also can potentially make it easier for GPs to refer through to our cancer services, then I feel that this is incredibly beneficial and will serve not only our local population, but is something that could then be disseminated out to a wider population. So in summary, our aim is to try and see if we can triage patients that get referred through in order to risk stratify them into high and low risk, and then get them seen by the most appropriate team in the most appropriate time frame. Thank you very much for listening. I'm more than happy to be contacted for any questions or any other ideas that you may have.